Yeah, thank you so much. Hi, everyone. My name is Trecy Hemedi. I'm a master's student doing pharmaceutical sciences and also a very avid enthusiast of keloid disease and pathology. So today I will be talking about the implications of 3D cultures on keloid research. And I have been starting on writing a systematic review, and so I would love to share my preliminary results with you all. So, as we all know, with keloid pathophysiology, there's a lot of cell culture that we need to do in order to understand the processes that happen that govern this keloid pathobiology. And currently, what we've been using so far are 2D models. Now, what 2D models lack is sadly a physiological context, complex signaling, and oxygen and nutrient gradients in order to really mimic the in vivo environment that is needed to infer conclusions to patients. But recently, there's been a lot of new 3D models that have been emerging, which have been used in a lot of research, which actually allow for cell-cell interaction to be measured and mimic the keloid tissue architecture, which is really great. Aside from that, it also it allows us to measure the mechanical cues, which is also a big part of the keloid contractility, for instance. That's something that's also one of the big characteristics in keloid, which now can be measured. And so because of this absence of the 2D models reflecting in vivo research, it is very relevant and necessary to start using these 3D models. Now, as people have been probably using these 3D models, it's actually quite funny because this is a study with Dr. Roland, who's right here. So it's actually quite funny that I read the research article that he's now in, full circle moment. Anyway, yeah, so he was looking, and his research team was looking at whether or not spheroids were actually a relevant model. And what he tried to do, what he actually did, is he added some TGF beta into the spheroids that he made from patient-derived keloids. I think he used them from female patients, and he used the earlobes. And he tried to assess all these genes expressions, basically, that are associated with fibrosis and fibrogenesis, such as, let's see, alpha S smooth muscle actin. And what you would expect if you were to add TGF beta to a cell, which would create a pro-fibrotic environment, is that also these ECM modeling or genes that are associated with fibrosis would also go up. But what he saw instead is that it decreased. And so also, if you look at the overexpression of alpha smooth muscle actin, it was also discontinued after the keloid fibroblasts were cultured from 2D to 3D. So that's quite interesting because you wouldn't expect that. And so that got me thinking, and it made me realize, well, okay, since these 3D models are known to be a better representation for patients, and yet here we find some findings that present counterintuitive results. My research question was, to what extent can these 3D spheroids actually be useful for outcome measurements in keloids compared to the traditional 2D models that we're using now? Which got me to my methods. I tried to pile up and compile as much evidence as I could within the next, with a range from starting January 2016 to March 2026, where I tried to find all research pertaining to 3D and 2D comparison studies where they looked at mechanistic outcomes like gene expression, maybe drug response as well, and also just solely 3D cell culture models, as only the inclusion criteria also included having only peer-reviewed journal articles. So I had found 151 that I identified, but I ended up only getting 12 that really fit the criteria. And so here's what I found. The 3D spheroid fibroblasts likely offer better in vitro drug response predictions than 2D fibroblasts. This is based on multiple papers, but for the sake of convenience, I added some graphs from paper from Choi et al. In 2024. What you're seeing in the little well area is actually spheroids, which are labeled, and these are viability labels, as you can see in the legend up there. The green fluorescent label means that they're alive, and if they're red, that means they're dead. And what they've done, they basically administered three types of drugs, so TAC, fluorouracil, and bleomycin, with different concentrations to see if the diameter and the volume of those spheroids would deteriorate. And as you can tell, not only after you add some concentration, the ratio of red to green gets also bigger, but they also end up getting smaller in volume. Aside from that graph, you also see another graph which basically shows the relative volume that has decreased as a result. Now, if we compare this to the 2D one, we had to use a different way to assess it because obviously with 2Ds, they're monolayer, so you can't really assess the effect of the drug on the volume. Instead, what they did is they used the viability, and as you could tell before, they used the viability here and the volume. Here, they only had to use the viability. But you still see that this one has considerably lower values, which means that also if you look in the literature, this aligns a little bit more with the characteristics of what patients would report. Now, a second thing that I was looking into was also gene expression, especially looking at markers that were aligned with ECM remodeling. So here you see that if you look at the blue graphs, those are monolayer cells, and you have spheroid cells, which are red. And on the x-axis, you see different types of fibroblasts that were used. So K1, K2, and K3 mean keloid fibroblasts, and F4E1 means the ratio of fibroblasts to endothelial cells. And what you're seeing essentially is that over time, in every concentration, every cell that you use, you see that the ECM markers are still elevated in the spheroid in almost all cases, literally all cases, except, they're just all significantly elevated compared to the 2D keloid fibroblasts, which is quite interesting. So my main takeaways from this are that 3D keloid fibroblast spheroids may offer a better prediction to the in vivo drug responses compared to 2D monolayer keloid fibroblasts. And at the same time, the gene expression profiles may be more elevated when using 3D spheroids compared to 2D monofibroblasts. These findings, by the way, were also reinforced by the other papers that I had not mentioned in here that I didn't use the graph for, but they also saw the same elevation, just different values. And so that's why I took them out just for convenience sake. As far as looking at the cells, when you administer TGF-beta with it to create a pro-fibrotic environment, that hasn't been done so far from the compilation of research that I've gathered. So for now, I'll leave that as something that is that in the future I'm looking forward to see what that result will give. But overall, from this systematic review, these preliminary results show some limitations. For one, it's the variability in study design. Because they're done by different researchers, of course, there is always a degree of bias in how you make these cells and how you culture them. I've tried to make sure that I've looked at the subculture number that they use. So how many times they passaged one. Usually it's between 3 and 5. So that's quite identical. But again, I don't know exactly which number they used. So that would be very good to implement a risk of bias for in vitro studies, which I'm looking forward to doing in the future. The second thing would be the small sample size and the keloid sample heterogeneity. Since the research articles in of itself did use identical keloid lesions from one place, so the research article by Dr. Ronald used solely earlobe keloids, whereas another study used chest keloids. If you want to infer the conclusion, since even within patients in different locations, they can still change up when it comes to, there can still be changes in the way that it behaves. I think it's still very important to take that into account and not overestimate the results and the conclusions that come from this. So I would suggest making more larger and more robust studies on the gene expression profile between the 3D spheroids and also the TGF-beta administration. Thank you for your attention.
Thank you. So, and thank you. I see we have a question from Dr. Lamont Jones, whom I had give a presentation on 3D spheroids 2 months ago in St. George's Hospital in London.
Yes. So congratulations for doing that review. And I think that it's an important topic. You know, all of us that do research on keloids, there are no animal models, there are no good in vitro models right now, and I think we know it's a complex disease, and we probably are going to have to create models specific for what it is that we want to test. When I was in actually last year, I mentioned that we were working on organoids, keloid organoids in my lab, and when I was in London in April, I gave a little bit of a talk. So I think there's only 3 articles published, 3 or 4 articles published on keloid organoids, the spheroid, and when you look at those models, they only have 2 cell types that are present. There's one with fibroblasts and one with endothelial cells, and the other one is just fibroblasts. And I'm hoping that in Paris next year we'll be able to present it. But in my lab, we have actually created an organoid that has 7 cell types in it. And I think the one in those studies that lasted the longest was, I think it was 6 or 7 days was the length. Our organoid has lasted 21 days, and we have characterized it with IHC. So we have fibroblasts obviously are present, but we also have immune cells. So we have macrophages, there's T cells that are present. We also have endothelial cells, keratinocytes that are present. And the thing that was most interesting and that I was most excited about is that we actually have pictures of the organoid with keloid collagen. So there's we have a picture that shows kind of like the swollen, hyalinized collagen, and ours is based off of using mitrogel. And so if you know mitrogel, it has a whole bunch of mixture of collagen, but the fact that the organoid lasted for 21 days and reconstituted what looks to be keloid collagen is very exciting. And so I think, you know, in order for us to understand what's going on and even test drugs in the high throughput fashion, just like you mentioned, organoids are probably going to be one of the models. It's probably not going to be the only model, but it's going to be one of the models that's going to get us closer to a yes or no in order to move into the to the clinic. Seeing that now, at least in the U.S., you don't need an animal model to get FDA approval. You can do it with in vitro studies. So I commend you for doing this review. And I know you mentioned yesterday you're interested in doing your PhD and focusing on keloid organoids. So I think we all would welcome your future contributions to kind of move this forward. So
thank you so much. I appreciate it.
Sorry.
Yeah, thank you for doing that. This is exciting indeed. In our lab, I use not keloid organoids and so on, but I've been, meaning to try working on developing them. But we do use spheroids and organoids for the cancer work that we do. And, I'm somewhat disillusioned by, the kinds of findings that we have managed to get from those. And one of the concerns was, and part of what you presented also shows that. So for example, in the spheroids, when you treat them with drugs, you see cell death on the inside, whereas the living cells on the outside. How do you explain that?
Well, I think that's because the oxygen gradient is usually a little bit denser in the middle, so it's harder for the oxygen, all the nutrients to get in. So it tends to get more necrotic over time. And I've been seeing that in a lot of studies that they have been trying to add some extra nutrients in there to keep it alive. So it does make sense that it starts to, well, die from the inside out instead of outside in. Yeah.
But that's my point, that what you're seeing there is an artificial effect of the oxygen gradient or nutrient gradient as opposed to the drug, or a complex interplay between the drug. And um, the big issue that I have with both spheroids and with organoids is the lack of a blood flow system that you would get using capillaries. So yes, in some cases, there would be an improvement over 2D cultures. In our hands, we ended up learning not that much beyond the 2D cultures with our 3D cultures. So I'm somewhat disillusioned by that. But I still hope that, maybe with more complicated organoid systems, I'm very excited here about Lamont's, 7-cell type system. Maybe with more cell type, maybe we'll be able to get a better mimic. But there are a lot more questions that would need to be answered before we can trust the data that is going to be coming out from there. I don't want to be a stick in the mud. I am excited about that.
No, I completely agree, actually. And that's why I actually really like this research, because it did make me question about how you view 3D models compared to traditional 2D models, and how you cannot just take any value for granted just because it's 3D. And so I think this kind of opened my eyes and made me realize, well, there are relative weaknesses and strengths to each model. And so now that I've been able and have been presented and have been exposed to that, you can kind of make a better assumption based on what it is that you want to measure as an outcome and see which one works.
Sure. So what else how else would you explain the effect of the TGF beta stimulation that led to a decrease in alpha SMA? Is that simply that you're not getting penetrance of your TGF beta to the internal parts of the spheroid, and because of which, or maybe this is a better question.
Yeah, I would like to yield it to the expert if that's okay.
Yeah.
There's an expert.
Oh,
Thank you so much. So first of all, congratulations for the talk and for sharing our non-satisfactory data.
You're welcome.
Regarding the question, and it's more a comment than an answer, I do think that the major difference between 2D classical culture and spheroid is the absence of plastic surface, of course, because in the spheroid model, the cells attached to themselves and not to a very how to say, high rigidity plastic support. The bottom of the culture well plate is about 3 gigapascal stiffness compared to 0 on the spheroid model. I think that it's an explanation regarding your question, because there's no high mechanical activation of the fibroblast itself on the culture surface. I'm very happy to know that Lamont has a very interesting model in his hand. And I do think that, of course, if we want to mimic the complexity of the keloid tissue, one cell type is not enough. So you're so right to have many cells as possible. You have illustrated that with the paper from Choi and collaborator. The only addition of endothelial cells to the model change everything. We think about macrophages, of course, and if I come back to the mechanical feature of the models, we try to think in my lab to how to integrate mechanical forces, mechanical strengths, mechanical rigidity into a 3D model. So we are moving forward to 3D bioprinting to modulate the stiffness, the rigidity of a 3D construct that we can build, integrating keloid fibroblasts, macrophages, endothelial cells, and so on, in order to try to reproduce the complexity of the tissue with bioprinting. Maybe we will have a presentation next year in Paris. I hope so. Lamont?
So I agree about the blood, but I think again we're not probably going to get every. Wow. And so the one thing that we're interested in for our model is the cellular interactions. And one of the things that we're doing, we're in the process of characterizing. We have we're fortunate that I'm able to collect the tissue and we can take it to the lab. So one of the things that we're doing is we're characterizing the matched keloid tissue. So we have single cell data. We've used cell chat to look at cellular interactions. And so our plan is to characterize, so we know the cell types are there. And so the next thing that we're doing is doing RNA-seq, just like I talked about before. You can computationally determine what cell types are there. I mean, there's some limitations. So you can't look at ratios of cells because you don't know what's going to happen with the cells. But you can look at interactions. You can look to see whether or not the same pathways are activated. And, just like what you talked about, one of the things that we're going to look at is to see how the cells respond to, how the organoids respond to TGF-beta. I mean, that's the most important pathway. But we will also be able to see whether or not this is patient specific, because some patients don't respond the same as other patients do to TGF-beta. And so I think when we look at the organoids, probably the best we're going to be able to get out of it is to look at cell-cell interactions and see how those affect patient response. And eventually, what we will be able to do is, if you take a patient, you make the organoid. If you treat a patient with steroids, you can look at the response. Then you can also compare maybe the response of the keloid to it and see whether or not there's a prediction. So I think that's where we're going to go in the future with organoid, at least in the short term.
Yeah, sounds very interesting.
Well, are there any more questions? Well, no. We'll thank you for your presentation, and we can now proceed to the reception. Thank you.
Much, and to the attendees by Zoom, unfortunately, we are running very late, so we have to postpone the questions from the Zoom attendees. Thank you very much for Zoom attendees to join us.
We have certificates for the people who are joining today for the speakers. So Juliette is standing there, and you have to take one, and then you can get a drink. And tomorrow morning, we will be fresh and awake and ready for even more discussions. Thank you for this nice and lively day.
Presented this.
And tomorrow we start at 9 a.m. Thank you.
9 a.m. Okay, 9 a.m.
That was what Lamont John. He had better.